Hey, welcome back, everybody. It's time once again for another journey we call Living Hope. Brought to you by Orange County's only community radio station. And hosted by, well, a woman who's brought living hope for a lot of people over the course of this program in the course of the last 20 years, as she's one of the survivors of this deadly disease, pancreatic cancer, and shares her thoughts and ideas with the world. Like today. I don't know where I'm going with this, Roberta. Help me out
I
here.
was going to say, where are you going, Paul?
I have no idea.
It's okay. Some days are like that.
Some days are like that here.
We just kind of wing it, right?
That's it. Well, you have a fascinating guest this morning here. I'm eager to hear more about the work that they do.
Yeah, thank you. I think he's pretty fascinating, too. I'm really happy that Let's Win referred us and connected us, so thank them for that. Dr. Wadlow is an oncologist at the Inova Schar Cancer Institute, specializing in medical oncology and internal medicine. He's involved in groundbreaking work at the Nova Saville Cancer Screening and Prevention Center and director of the High Risk Pancreatic Cancer Clinic. Did I get that correct, I hope?
You did? That's Inova Schar.
Oh, well,
Close enough.
sorry. I'm really bad at pronouncing things. I'm surprised
That's okay.
I got it right halfway. So thank you for joining us today. We really do appreciate it. And you said in Virginia?
Fairfax, Virginia, right outside of Washington, D.C.
Oh, awesome. Well, thank you for joining us today. And can you tell us what your connection is, or do you have a connection with pancreatic cancer?
I do. Thanks, Roberta. First of all, I'm really pleased to be here. Thank you for the invitation. So I am a gastrointestinal oncologist, and therefore I see a lot of people with pancreatic cancer and other gastrointestinal malignancies, including colorectal cancer, stomach, liver, gallbladder, cancer, esophageal cancer. Pancreas cancer became an interest of mine when my mother was diagnosed with stage 4 disease in 2000, when at the time I was doing my residency in internal medicine at the University of Pennsylvania. She went on to get chemotherapy and lived for a year and a half, and then succumbed to the disease in October of 2001. I finished my residency and then applied for and was accepted into a hematology oncology fellowship at the Dana-Farber Cancer Institute and Massachusetts General Hospital in Boston. And after that, I have done quite a few different things, including laboratory-based research in solid tumor biology, the way different cell populations make up pancreatic cancers, then in clinical trials investigating new drugs for pancreatic and other gastrointestinal malignancies, and more recently in screening patients that are at higher than typical risk for pancreatic cancer.
Are you comfortable talking about your mom a little bit more, or would you prefer not to?
No, I'm very comfortable speaking about her. My mother, Emily Couric, was a state senator from Virginia. She grew up in Northern Virginia here, went to Yorktown High School in Arlington. I still meet people who knew her or even went to high school with her. She subsequently remarried my stepfather in 1982, who was the chief of cardiology at the University of Virginia. We moved to Charlottesville, even though I remained very close to my father, who continued to live in Northern Virginia. And my mother then went into school politics. She was the chairwoman of the Charlottesville City School Board, handed me my high school diploma when I graduated. And she was also a writer about the legal profession. She was not a lawyer herself, but she wrote several books about trial lawyers and divorce lawyers. And she subsequently decided to run for office in 1996. She ran for state senate, and she unseated the Republican incumbent and was reelected to a second term, and was serving as the state's Democratic Party chairwoman when she was diagnosed with pancreatic cancer, and was also running for lieutenant governor at that time. While she was treated, she never missed a vote. In session in Richmond, she would go over to MCV, Medical College of Virginia, and get intravenous fluids when she was dehydrated from chemotherapy. But she did have to drop out of the race for lieutenant governor, and Tim Kaine took over, and he and Mark Warner won, and then Tim Kaine went on to be Hillary Clinton's running mate. in the presidential election, and is still a U.S. Senator from Virginia. So many people feel that my mother would have been the first woman governor from Virginia.
Oh wow, that would have been amazing, right? Did your mom have any symptoms, or how was she diagnosed with pancreatic cancer?
Like many people, she had non-specific abdominal symptoms. She didn't relish talking about her symptoms with her son, even though by that time I was a fully formed adult and a medicine resident. I was living in Philadelphia and newly married. But I was able to learn from her over time and from my stepfather that she'd suffered for some weeks, if not several months, with abdominal bloating, change in bowel habits, just not feeling right with those vague abdominal symptoms that so many people have, but which are usually due to benign, limited causes. And that was what she was told for quite a while until she eventually finally was able to get a CAT scan, which at that time unfortunately showed that the primary tumor in the tail of her pancreas had already spread to her liver in several locations.
And the treatment she received was chemotherapy at that time then?
She had multi-agent chemotherapy with many of the same drugs that we are still using today, almost a quarter century later.
Would you say much has changed or not much has changed since your mom's diagnosis?
I think it depends on how you define much and not much. The median survival, all comers for pancreatic cancer at that time was less than 5%. It's now 13%, pretty modest improvement, but substantial for nonetheless. And she, although she was treated, as I said, with many of the same drugs that we use today, we had made progress in terms of understanding the genetic and molecular underpinnings of pancreatic cancer. In 2000, there was no comprehensive molecular profiling, which now is the standard of care for all patients with advanced pancreatic cancer. And it's still the case that we're only able to use molecularly targeted or immunotherapies in the minority of patients. That percentage is going up as we sort of learn more about the underlying biology of the disease. So we've made some substantial improvements, but still have quite a ways to go.
Yeah, can you explain that to the layperson a little bit about the immunotherapy?
Sure. Yeah. So chemotherapy has been around for quite a long time. And there are many different kinds of chemotherapy, just like there are many different kinds of antibiotics. And the ways in which chemotherapies were put together and used in different recipes, if you will, for different cancers was largely derived empirically on the basis of clinical trials that at one time were basically solely conducted by the National Cancer Institute and the National Institutes of Health. And they sort of have a legacy, and they work by poisoning the mechanisms cells use to divide their DNA and make copies of themselves. They have toxicities, however, because we have normal cells in our bodies, like the cells that give rise to our hair follicles, our blood from our bone marrow, the lining of our gastrointestinal tract, that also are dividing, and therefore we get the classic toxicities of chemotherapy, including nausea, vomiting, diarrhea, mouth sores, hair loss, and low blood counts. What has happened with the revolution in molecular biology is that we now understand a lot more about what the actual mutations are that give rise to different cancers. And not only that, we're able in a cost-effective manner to get molecular genetic profiling of each individual cancer in a time fashion that is conducive to potentially personalizing therapy for each individual. The problem has been that cancers often, and pancreatic cancer is notorious for this, are incredibly complex in multiple ways. And one of those ways is in which there are many different mutations, and it's not at all clear in many cases which mutations are driving the cancer. And even when we know, it's been very difficult to develop drugs which knock out the proteins that are encoded by those mutations. So that's what we call so-called targeted therapy. When we take a tumor from an individual, we profile it, we find mutations in that tumor, we understand that one of those mutations is sort of like an Achilles heel driver of that tumor, and we have a drug that can knock it out. It's typically not a cure, but it often can substantially reduce the amount of cancer somebody has and prolong their life in a meaningful way. More recently, immunotherapy has come onto the scene as a way in which to tip the balance, the battle between cancer and the immune system back in favor of the immune system. So one of the ways in which cancer becomes cancer is by learning to disguise itself from the immune system. So we all, as we age, our cells are constantly, when they divide, there are errors, but we have sort of housekeeping systems that go through and clean up those errors so that we're not getting cancer all the time. Occasionally, those errors are not fixed and a cancer develops. But one of the things that has to happen again is that the immune system has to be tricked into thinking that this is a normal part of your body and should not be eliminated. Immunotherapy really developed based on some seminal discoveries by several people, in which it was learned that if we give drugs that sort of one common analogy used is disable the brakes that have been engaged by the cancer system, so reawaken the immune system, it will attack the cancer and sort of re-recognize the cancer as foreign and eliminate it. Of course, that sounds very nice in concept, and it works quite well in a variety of cancers, but in pancreatic cancer, it's been very difficult for reasons which I'm happy to go into, but that's an ongoing area of research.
I was just going to ask you the reasons because I know it is a very difficult cancer. So could you please explain that to us then?
Sure, yeah. So these immunotherapies are, for the most part, antibodies that block braking mechanisms on immune cells called cytotoxic T cells, which are the cells that bind to foreign proteins or so-called antigens, whether they're from bacteria or tumors, and target those proteins for elimination by other parts of the immune system. For these antibodies that disable the brakes to work, the immune system sort of, using the braking analogy, the immune system car or vehicle has to be in the vicinity of the tumor. If you're giving a drug to disable the brakes on something that's not anywhere close to the scene, then they don't work. And so tumors are often thought of as being immunologically hot or immunologically cold. Hot tumors are tumors where T cells are in the area, they just can't quite do their job. They're losing the battle. And a switch in the right direction can sort of tip the scales back in the favor of the immune system. But if they're not there, as in the case of immunologically cold tumors like pancreatic cancer, those brake disablers, or what are called checkpoint inhibitors, are not sufficient to tip the balance back in the favor of the immune system. So the trials that are ongoing are looking at ways to get these immune T cells to traffic to the cancer so that these checkpoint inhibitors can work more effectively.
And you have clinical trials going on right now for that?
We do. There are clinical trials going on at cancer centers around the world, certainly around the country, at our institution and other institutions with whom we partner.
And for the clinical trial, how long is the clinical trial, or does it vary?
Depends on the specific clinical trial. So there are many different clinical trials, many different ways in which this strategy of immunotherapy combinations or immunotherapy combined with new targeted therapies are being investigated. So it really depends on the details of the trial. Typically, when a patient is diagnosed with pancreatic cancer, if they are in an area where trials are not available, what I always counsel people to do is to make sure they're linking with one of the national organizations like PanCan or Lustgarten or any of the different organizations that could help those patients identify clinical trials that might be appropriate for them.
Thank you. That was the next question I was going to ask you, because I know when you Google clinical trials, I mean, there is a government website as well, but it's so difficult. It's, and you just look at it and it's just like you don't even want to do it. You want to kind of give up. So I'm glad there's places out there they can go to and kind of take that off the plate and make it a little bit easier.
Exactly.
As far as what is PRECEDE, I hear a lot about this, but what is that exactly?
So thanks for asking. PRECEDE is the Pancreatic Cancer Early Detection Consortium. PRECEDE was started in 2018 by a group of like-minded investigators. The original institutions included New York University in Manhattan. And the basic premise was to collaborate, to agree to share data, to start a registry trial in which individuals at increased risk of pancreatic cancer, either because of a family history or a genetic predisposition or both, could be screened, and we could learn better ways to find pancreatic cancer before it made people sick, like it made my mother sick, and at an earlier, much more curable stage.
And so what would be their basic goal then is just to share this information and get it out there to all the other scientists and researchers?
Yeah, so the number one goal of PRECEDE is to increase the 5-year survival to 50%. As soon as possible, but the stated goal at the time of formation in 2018 was to do that within 10 years. That's a tall order, given what we talked about at the beginning of this interview, which is that it's still only 13%. The way in which PRECEDE hopes to do that, again, is by identifying people that are at greater than average risk, learning as much as we can about how to screen them, and then extrapolating those results to the general population.
And then what are some of the key challenges for in this?
Yeah. So some of the key challenges are that this takes time. Even people at high risk don't often develop pancreatic cancer. So the average person's lifetime risk of developing pancreatic cancer is around 0.5 to 1%. Some of the high risk populations that are more common, like for example, people with mutations in genes like BRCA1 and BRCA2, still only have a lifetime risk in the neighborhood of 5%. And so most of them will still not develop pancreatic cancer. Other people at high risk include families where there are at least 2 first-degree relatives who've developed pancreatic cancer. Many of them have negative genetic testing, so we need to understand what it is that genetically is causing the increased risk in those people. But a challenge has been getting a study that's large enough so that we can identify enough people with pancreatic cancer, hopefully at a point that's early enough in time where we can cure them, prove that screening actually saves lives, and then learn more about tailored screening strategies. For example, who really needs to be screened versus who's in a high-risk group but really doesn't need to be screened. And then, of course, right now, we need more effective and cost-effective screening strategies. So the screening strategy that's used today is abdominal MRI, typically alternating with endoscopic ultrasound. Neither of these are easy or cheap tests. So a lot of work is going into identifying blood tests, which of course would be a lot easier, a lot more cost-effective.
What are some other high-risk individuals? What would that include?
So I touched briefly on familial pancreatic cancer, which is the name of the syndrome where if you have a first-degree relative who's been diagnosed with pancreatic cancer, and that individual in turn has at least one first-degree relative, so a parent and a grandparent, or a parent and an aunt or uncle are the same side of the family, or a parent and a sibling, you are defined as being at high risk because of this syndrome of familial pancreatic cancer. PRECEDE is defining that as also requiring negative genetic testing, so we don't understand what the genetic basis of that familial transmission is. That's a very high-risk group. Other high-risk groups are people with known mutations, so we talked a little bit about BRCA1, BRCA2. There's also PALB2, which is known for increasing the risk of breast and ovarian cancer. And there are about 8 or 10 other genes that have been associated with an increased risk of pancreatic cancer, some of which have a very high risk. For example, a gene called CDKN2A, which is also associated with familial melanoma. And there are other syndromes as well. So identifying those people and really targeting them for pancreatic cancer screening is the main initiative of PRECEDE.
If somebody does have the familial connection, when should, like, their children or their siblings, when should they be tested? Or should they be tested?
Yeah, so the recommendations right now are that anyone with a family history of pancreatic cancer and a first or even a second-degree relative should receive genetic counseling and consider genetic testing to understand whether or not they may be a mutation carrier. In terms of screening, there are different guidelines. The guidelines that are most commonly used are the National Comprehensive Cancer Network guidelines, NCCN, and then the CAPS guidelines, the Cancer of the Pancreas Screening Guidelines. And those guidelines basically are founded on data showing that screening can be effective and expert opinion in patients with either meet those criteria for familial pancreatic cancer. So again, a first-degree relative who in turn at least has a first-degree relative, or they have either one of the very high-risk genes like the CDKN2A that I mentioned, or another one is called SDK11, or they have one of the lower risk genes. When I say lower risk, I mean lower than those genes, but still higher risk than the average population, like BRCA1 or BRCA2, and a family history in at least one or second-degree relatives. So it gets a little bit confusing, I think, for some people, Roberta. Sometimes it takes a while for me to say it, so that's understandable. What I tell folks is that if they have someone in their family who's been diagnosed with pancreatic cancer, they should really seek to understand and potentially get genetic testing. That's the first step. And then they should have a conversation with their doctors or somebody who is involved in the field to discuss whether or not screening is indicated and appropriate for them.
So would they get that information maybe from their general practitioner, or do they need to see a specialist?
You know, increasingly we're trying to get the word out, but this is not an area that's as far along, for example, as breast, colon, or prostate screening, cervical cancer screening. So the general practitioner community may not be fully informed about what's happening, and in their defense, there's not as much data for pancreatic cancer screening as there are for those other cancers. So I think a lot of this is also about educating the public and continuing to work with organizations that support people with established pancreatic cancer. So there's now a universal recommendation that everyone with pancreatic cancer should get genetic testing, because ideally we want to know from the person who's been diagnosed with pancreatic cancer, are they a mutation carrier? Because then we can test all of their first-degree relatives and figure out who has the mutation versus who doesn't, and make appropriate screening recommendations on that basis.
And then where would somebody go, like myself, who has been diagnosed? Where would I go to get that screening done?
Genetic testing could be done in any cancer center that employs genetic counselors. So for somebody like you who is a pancreatic cancer survivor, you're not really somebody who's being screened for pancreatic cancer anymore. You're under surveillance. So you're a different population because you've already had pancreatic cancer and you're being watched closely, presumably by your healthcare team, to make sure that you don't have any evidence of recurrence, or at some point, if that becomes not likely, that you don't develop new cancers. The screening population are the people that have never had pancreatic cancer before and that are at increased risk. And typically they're screened now in a PRECEDE site or another site of expertise that is not only ordering abdominal MRIs and endoscopic ultrasounds, but working sort of as a collaborative group with the pancreatic surgeons and the other professionals who can sort of make group coordinated, collaborative, and consensus recommendations about what makes the most sense for each individual patient.
Yeah, I'm followed very closely because I actually still have my tumor. It's just dormant at the time. It's just not doing anything. Thank goodness, and it can stay sleeping for as long as it wants to, right? But
I hope so.
yes, but I have gone. It's been a few years, and I know we're going to redo it again because when I went in, it came back inconclusive. So I don't know. Hopefully that things have changed a little bit since that time. But I will be getting it done again because I have two sons that we are concerned about as well, and.
Right.
You know, my family history pretty much is I've lost 4 family members to mother, father, grandmother, and uncle. So it's on both sides of the family. So it's a little scary and a little concerning. So what
It is.
What is the best thing? I mean, to try to get my boys in to get anything done, but even to get their doctors to kind of do this, to do any kind of screening or any kind of test, has been like pulling teeth.
Right. And we typically would start at age 50, even in high-risk populations or high-risk patients. Pancreatic cancer tends to be a diagnosis in older age, in the 6th or 7th decade of life. So we want to start obviously before that. So that's where the age of 50 comes from. We need more data to support that. Or there are people, of course, being diagnosed at younger and younger ages. So if somebody's high risk and they have a family member who was diagnosed at a younger age, we'd recommend that they start screening 10 years before that family member was diagnosed.
That's a good point. Yeah, I was diagnosed at 45, so
Right.
I need to get my boys in.
Yes.
Um,
Yes.
what advice would you give to patients and families that just got that pancreatic cancer diagnosis?
That's a great question. It's, any cancer diagnosis is devastating. It's devastating for the patient. It's devastating for all the people that care about that individual. Pancreatic cancer has its own unique set of challenges, which are many. I think the advice that I would give is to seek to understand. Surround yourself, if you can, with people that can help you ask questions when you're not feeling physically up to it or you're feeling emotionally overwhelmed. And make sure that within 1 or 2 visits, you feel confident at sort of a very core emotional level that the people taking care of you are going to do right by you, that they're going to work hard for you, that they will be there for you, and that you are going to get the care that you need and deserve. I think that is the fundamental advice I would give to anybody with a pancreatic cancer diagnosis. And then stemming from that, despite the devastation of the diagnosis, there is lots of cause for hope. And so everybody needs to find their own unique blend of pragmatism and hope. And hope is critical to moving forward, to finding the right treatment, to hopefully being part of a cutting edge clinical trial, making sure that all symptoms are being aggressively managed, making sure that if you have an oncologist who can't do everything by themselves, that they're working with a team of professionals that can meet all of your needs as a whole person.
Very good advice. Thank you. I appreciate that. And I think Paul has a question for you.
First of all, I want to thank you for coming on. This is the most educational, informational, and yet detailed explanation of where we're at today with cancer screenings. And I'm wondering, what can we, the general public who hear this show, or those who are already dealing with pancreatic cancer who might be tuned into this show, what can we do to help you guys reach this lofty goal of changing the survival rate? Is it more money? They go to Washington and advocate. Do you need more dollars to fund research? Is it more awareness to get in and get screening done earlier? Is it more awareness in the medical community so they don't just dismiss it as, oh, you got an upset stomach? I hear all these things, and I wonder, what can we do other than just sit and wait and hope?
Thanks, Paul. I really appreciate that. Well, like any self-respecting cancer researcher, of course, I'm going to say all of the above. But, what I would say is there's still, I think we don't talk about cancer enough, believe it or not. We're doing a much better job than we did a generation ago, but there are still many, many families where we don't really understand our own family history. And I think it's because it's painful. And people don't always like to talk about what happened to, the grandparents or their parents or what the family history is. But knowing your own family history, asking questions, making it acceptable to sort of seek help when people have symptoms. And then in terms of making progress in treating this disease, getting out there, raising funds, raising awareness, talking about what we know versus what we don't know in pancreatic cancer treatment and screening, being part of communities, online communities are really blossoming, providing support for patients and families, many of whom have social barriers to healthcare, whether it's financial burdens or food and housing insecurity. So I was walking up the escalator, riding the escalator up in my cancer center just today, and took a fresh look at some of the people down in the lobby who were giving directions to people and just wheeling them out to the car, the volunteers, and just felt this profound wave of gratitude for them. So I think, the smallest things can be very meaningful. So whatever feels right and whatever is the low-hanging fruit for you in your community.
And of course, we need to add and tune into this podcast.
And tune into this podcast.
Right. Exactly.
Absolutely.
Thank you for that. I appreciate that. Well, I think our time, it goes by so quickly, and there's so much more I want to talk about. So hopefully maybe you'll agree to come on and another time and we can continue this conversation. But
I would love to.
well, thank you. I appreciate that. And as long as you speak my name, I shall live forever is dedicated to Emily Couric. Emily died of pancreatic cancer at the age of 54 in 2001. Thank you, Dr. Wadlow, for everything you do, for not just for your mother's memory, but for all of us survivors and patients as well. Thank you.
Thank you, Roberta. Thank you, Paul. I've really enjoyed this. It was very meaningful for me.
Thank you.
Well, there you have it. One more reason to tune in each and every time to this journey we call Living Hope, a weekly program designed to provide hope, inspiration, and education for those living with pancreatic cancer, sharing the real-life stories of those really affected by this deadly disease and how they deal with it on a daily basis. And if you'd like to share your story or have some other information you'd like us to broadcast, please contact us here at the station. And if you or anyone you know needs immediate help, lots of organizations we've rattled off. Some of them, let's mention one more, letswinpc.org. Lots of places to go seek help, seek counseling, seek support, and seek information like this. Thank you so much. We hope you'll join us again. And most of all, share this with somebody you love. And come back and join us next time on Orange County's only community radio station, OC Talk Radio. Streaming live from our studios here at the University of California, Irvine's Beale Applied Innovation Center.